Actually, Dr. Saravanan needs no introduction. He is the HOD of the retina unit for many years in Aravind Eye Hospital, Coimbatore. Fantastic vitreoretinal surgeon. Trained so many people. Actually, he should not have been called for a medical retina topic, but more for a surgical topic. But fortunately or unfortunately, we have only that this thing to come. So, sir was the first VR surgeon from Aravind, and he's had outside postings. He's trained a lot of people. We are very honored to have him here today. So I'll invite him for the keynote address.
Thank you, madam, for the kind invitation as well as introduction. So this will be just go through some of the treatment options which have happened throughout the years, at least during my both learning as well as now current scenario. So as you know, diabetic macular edema is one of the commonest causes of vision loss amongst working age population. So it's approximately it's 18.18 million people are suffering from diabetic macular edema in the year of 2020, according to one of the assessments. So this is the number one cause of vision loss in where the person is working. Like if they are in the top of their professional ladder, they may be a dean in a college, or they may be a manager in the office. So that's the time when this hits them most, and they tend to lose a lot of work as well as professional difficulties carrying on with their when they are at the peak of their career. So as you know that we have two types of damage happening in diabetic retinopathy. One is because of leakage as well as because of ischemia, and ischemia causes the bleeding complications, while leakage causes the edema complications. And conventionally, this is how we have been treating with the focal laser or grid laser for the DME, as well as pan-retinal photocollection for the bleeding complications. So these were the older options which we had. And you can see this is one short video showing the laser being applied. So in the olden days, we never aimed for vision improvement. We just happy with the vision stabilization. And focal laser was mainly aimed at stabilizing vision. Only a few percentage of people tended to improve in vision. And usually it takes more than 3 months for the hard states to resolve. And this is how it happens after the treatment. For a complete resolution, it may even take more than 6 months also. So you can see here, this is what we were initially doing for these guys. But you have to remember that edema is not a constant disease. If the sugar control is super good, then the edema resolves on its own. But we are creating permanent scars by doing laser treatment. So the collateral damage, both in loss of visual acuity as well as color vision and as contrast sensitivity, everything was very bad with focal laser. So focal laser, even though it was a standard care, it is not still the best option because we are creating unnecessary collateral damage to the critical areas of the retina. So then came the first injection that was triamcinolone, which is an off-label use, which was mainly used for orthopedic surgeons. And we were injecting this in patients, especially with the diffuse macular edema, because focal laser used to work well for focal maculopathy, but for diffuse macular edema, the grid laser was not that very effective, and we used to have very poor outcome. And in those days, the first godsend gift was triamcinolone. So, but the problem with triamcinolone, you can see, as you all know, the cataract as well as glaucoma, plus the rebound effect. So, when you have third or fourth injection, the response to the injections down the line is less compared to the first. First injection will work like magic, but the later on injections do not work that very well. Just showing some response to the intravitreal injection in one of our old cases. So this is mainly acted by making the blood-retinal barrier more stronger, as well as had a smaller effect on the VEGF component also. So mainly thereby decreasing the capillary leakage and decreasing the fibrin deposition. And also in the chronic macular edema, you have a component of inflammatory component, and this was mainly taking care of those cytokines involved in this DME pathway. Then to decrease the side effects of steroids, we had the era of anti-VEGF. Macugen was the first, mainly for AMD. Then we had the Avastin, Lucentis, and the Eylea. So amongst this, Avastin is the most popular because of the cheap cost, but otherwise the standard of care has been Lucentis, and nowadays it has shifted to Eylea. In outside countries, now the standard of care is Eylea for DME. So there are multiple trials showing the efficacy of these drugs in patients with diabetic macular edema, and there's a lot of studies for all the drugs, aflibercept, Lucentis, as well as they showed the efficacy and the safety also. But you look at which drug works well amongst the three. we had that in eyes with poor presenting vision, aflibercept was better, but otherwise in patients with low minimum vision loss, there was no big difference amongst these groups. So also if you see the persistent macular edema was lesser with aflibercept, and the worst was with the bevacizumab or Avastin. Avastin had the persistent edema, more risk of having a non-resolving edema down the line at the end of 1 year follow-up in one of the studies. So then we had the protocol T extension study, which showed that the protocol T showed that aflibercept was better in eyes with poor visual acuity. But the extension study showed that even after after 2 years, people still had edema, and when they were left to the doctor's discretion, the outcomes were not that very good. So vision did not improve beyond 2 years, and a lot of people tended to lose vision, but most of the patients were tended to maintain vision. But the improvement in vision was not able to sustain after the 2 years study period. So then there was to decrease the treatment burden. So there are a lot of things have been coming up. This is one of the devices from the Novartis and Roche. So this is actually sort of an implantable depot. So because they could not make the Lucentis to act longer, you just insert this depot into the eye, and then you can fill it up whenever you want. And once you fill it up, it works for 6 months. So you just implant this device and then suture the conjunctiva and tenons over it, and every time you have to inject the drug into this reservoir. But the problem with this was that the septum which holds the drug inside tended to dislocate, and almost 3% dislocation was seen in the first study, and now it's not in the market right now. It's still called back, and I don't know when they'll reintroduce this. This was able to sustain the efficacy of ranibizumab for 6 months. So to increase the duration, then we had the advent of Ozurdex also, which promised a 2 to 3 months follow-up, efficacy on follow-up. And then the Iluvien implant, it is very good because we had 2 formulations for Iluvien. Just showing a video of the Ozurdex injection. So the Iluvien implant also is a small pellet, whereas Ozurdex is a biodegradable vehicle, so the whole pellet dissolves. Whereas the Iluvien implant, which has the fluocinolone acetate inside this dexamethasone insert, but the Iluvien is similar, everything is similar, but you have a non-biodegradable pellet sort of thing. So you have 2 membranes through which the drug will perfuse into the vitreous cavity, but the vehicle itself will remain for lifetime. So this is the response to Ozurdex. And this is the Iluvien implant, which is here, this is a non-absorbable pellet. So drug is inside, and you have 2 permeable membranes through which the drug will be slowly released. We had 2 formulations, one was 0.2 and 0.5. 0.2 worked for 1 year and 0.5 worked for 3 years. It was super efficacious, but the side effect was very high. So we did around 35 cases in our hospital. So it was we had almost 100% cataract at the follow-up of 2 years, and almost 30% had glaucoma, of which probably 10% needed glaucoma surgery. So because of these complications, FDA did not approve it for routine use for diabetic macular edema. Then we had the advent of micropulse laser to decrease the collateral damage. Instead of a continuous laser, we had delivery of the laser beam in small packets, so that before the heat can permeate into the retina and cause collateral damage, it stops. So the choroids get heated, and then before the retina achieves the whitening, the laser is stopped. So here, how does it work? It mainly induces a lot of reparative process, and also some formulate that it acts on the tumor necrosis factor alpha. So thereby, the reparative process helps to resolve the edema. So this is how the micropulse works. Before the retina gets burnt, the laser stops. So mainly it inducing some sort of reparative process. The exact mechanism is still not known, but they say that tumor and TNF alpha plays one of the major role, and this is the parameters which are routinely used. But even though the results, the trials were very promising, in real life scenario, it was not very promising at all. We had a trial between Arvind Madurai and the LVPI Hyderabad. So they had to stop the trial in between because the response was very poor. So even though the company-sponsored trials showed very good response, it was not able to replicate in real life scenario. And this is one of the cases where you can see the laser is being done. So first the energy is titrated, then it's converted to a 5% duty cycle, and then you can see the laser being delivered. So you'll not have any perceptible burns after the end of this. Actually a CSR case. You can see the micropulse laser being delivered. So you'll not see any endpoint here. Unlike routine focal laser, there'll be no whitening, so there's no collateral damage. But the real world scenario, the efficacy was not as described in the trials. Then we had the new drug which came to the market right now, the Peginax or brolucizumab. It offered 2 to 3 months efficacy. It's mainly a humanized mononuclear single chain variable fragment. that works on VEGF-A. So a lot of trials showed that it is efficacious. Some trials showed it's better than aflibercept, but clinically, if you see, we are also using it. But unlike AMD, where brolucizumab has a super efficacy, it is not so in DME. DME has only very moderate efficacy, more or less equal to Lucentis or aflibercept. So maybe the duration is slightly longer, but the efficacy-wise, it is not that very spectacular. But if you do in a ARMD, the efficacy is very spectacular. DME did not show such great results. So some trials showing the response to brolucizumab, and this is a very large trial with more than 650 patients. They showed that it was more or less equal to the aflibercept. It was not very big. Only thing that it may have a slightly longer effect than the Lucentis. Then we have the new drug which is coming into the market right now, that is faricimab. It's a bispecific monoclonal antibody which acts on both VEGF-A and angiopoietin. Angiopoietin mainly sensitizes the tissue for the action of VEGF-A, and also it has got minor action, so it helps to directly inhibit VEGF also, but it both acts directly on the VEGF and also helps to suppress angiopoietin, thereby decreasing the sensitivity of the tissue to VEGF-A. So the efficacy here is proven to be 3 months, and people are very happy with the efficacy. It really works for 3 months, which unlike brolucizumab, which was not really giving that much long effect. So the Bolivar trial, which is a major trial, showed that it is really efficacious, and you can give it once in 3 months, 3 to 4 months, especially in some of the trials they showed that. So this is about the drugs itself. Then there have been a lot of research going on into how to enhance the efficacy of the currently available drugs. So topical, now one new drug is going on trial in Arvind. So, but main barriers for topical delivery is that the lot of washout happens at the tear film, corneal, and the aqueous. So a lot of things get washed out. People have also tried conjunctival transscleral effusion, but there also the choroid tends to suck off all the drug, thereby limiting the retinal exposure to the drug. So there's have been a lot of barriers here. But right now, a lot of research is going on into this non-biodegradable implants, nano formulations, and hydrogels. But till now, there is no promising drug in the market at this point of time. One drops is just entered for trial, so we'll have to wait and see how that performs. So these are now current directions to enhance the efficacy of currently available drugs, and most of these drugs have been using Avastin as a molecule for them. So these are the parameters which they are looking at, how to enhance the what are the requirements for a correct delayed drug delivery system. So right now Avastin is going a lot of drug trials in these formulations. And the last thing we will be trying to say is the gene therapy, where here we are using a adenoviral vector and using a functional gene, and this is either injected in the subretinal space or the suprachoroidal space, and it will be acting like a biofactory inside the eye. So this will be producing the VEGF inhibitor inside the eye. So we do not inject separately, the gene will be producing. So this is showing the Region X bio trial, where the approximately 250 microliters of 3 billion gene copies are injected in the subretinal space after doing a vitrectomy, and fluid exchanges are done after this, and then it is closed. So minimal vitrectomy, subretinal injection of the genes. So now these genes will be sitting using adenoviral vector, and these genes will be sitting in the eye permanently, and you have a permanent biofactory inside the eye. So this will be used to these will be manufacturing the VEGF inhibitor right inside the eye, so there's no need to inject it later on. So there's one more trial which has been showing some promising results. One of the Indian is only doing the main, this is again by the AbbVie, or the now Allergan, which has been taken over by AbbVie. This is the RGX314 gene, and they have 6 months results have been very promising. They show that it's equal to steroids in decreasing the diabetic macular edema, and this is how it is given in the suprachoroidal route, a short needle, so that doesn't penetrate the choroid. So it is given in the space between the sclera and the choroid, and this tends to permeate. And so both gene therapy has been tried in both these routes, both subretinal as well as suprachoroidal. And these are some of the newer directions which are looking at to enhance the efficacy as well as to prolong the effect of the currently available drugs. Thank you. I'll stop here.
Thank you, sir. That really was the telling you what is happening in diabetic retinopathy. Now my talk is going to be about why we want to do all this. Why are we so bothered about getting more and more newer things? So you will be here for some time. Okay. So, good afternoon to all of you, and I thank KSOS for this opportunity. Sir has talked about what is there in studies as well as real life scenarios. Now in diabetic retinopathy, our real life scenario is not very good. We have tried our best in most of these things. We do laser, but everything is inadequate. Maybe the treatment is inadequate. Maybe the working mechanism, as Sir said, after 2-3 injections, the effect goes. So what are we trying to do and why is it important? So we are trying to prevent severe visual loss. So the first thing that you should know is what is severe visual loss. It is easy to say it is 5/200 less than. What do you mean by 5/200? That is at a distance of 1.56 meters, you are not able to see the top letter. So just seeing that top letter there at 1.56 meters on 2 consecutive 4-month period. That is your ETDRS, this thing. So what is the treatment? Treatment is you have to get treatment as soon as possible for diabetic retinopathy to prevent severe visual loss. That is the only thing. Now what is the cause? It is one of the leading causes. It is a pandemic now. So this sight-threatening diabetic retinopathy is the part which we have to start recognizing. So this is the severe NPDR stage, the PDR stage, and the diabetic maculopathy, which if left untreated will go into severe blindness. So the prevalence is 1/3 of diabetes have diabetic retinopathy. Out of this, sight-threatening diabetes is 10.2%. That is 28 million people with diabetes have STDR. That is not the only thing. They are all coming up. Further and further, you are going to have a very large population who are going to go blind if you don't know what to do. So what is the preventive step? Basically, increase awareness and do systematic screening. And now there are personalized retinal screening strategies where it depends upon the age, sex, duration of the disease, the anti-diabetic medication, HbA1c levels, and the life expectancy. So in the rural setting, they have sort of given these charts which are predictive models for the next 3 years what is going to happen to you. So if you are on 2 drugs or if you are on insulin, if you are a male or a female, they have given percentages which tell you that this is going to be your 3-year risk for developing diabetic retinopathy. So that the patient will also be there aware of it. So the diabetic retinopathy increases significantly for every 5 years of the duration, but if it is after 60 and that patient does not have diabetic retinopathy, or if it is after 20 years of age, then it is less likely that he will get DR. Now the main point is that we have to detect early DR. Now what is that? That means that you have a dot hemorrhage or 1 or 2 microaneurysms. And here you must, once you see this, you must have a close relationship with your primary care physician. And we can do, these are the things, standards which we are doing, that early NPDR can go on to the mild to severe variety, from where it goes on to proliferative. And for these, the mild to severe, till now we are just observing and controlling risk factors. For the PDR, we know that we are doing PRP. It can also progress into the non-center involving maculopathy or the center involving maculopathy. The non-center involving, still it is laser, focal laser, and for the diabetic maculopathy involving the center, it is anti-VEGF. So now our question comes, how do we prevent progression? So we know that we can control the risk factors. Can we do anything better? So there was this oral phenofibrate, which is an anti-lipid lowering agent. It had studies, it did tell us, but because of certain problems, it went off. But it is slowly coming back. So there were 2 major studies, this phenofibrate intervention and event lowering in diabetes, and the ACCORD study. What it told us, basically action is independent of diabetes, the lipid lowering agent. It's not basically an anti-lipid lowering agent that is working. It is something else. It is down-regulating VEGF, it is preventing leakage. So the doses that we give is 160 to 200 milligram. In field study, they found out that there was a 31% reduction. What they did was they took 10,000 patients who got this drug and 10,000 patients who were just followed up. These people, all of them, both the groups had diabetes. So after a few years, they found that those who took this drug did not have as much the laser requirements as the other. So the first laser was less, and the first vision-threatening DME was less. So that means there is one way of preventing it, may be giving this drug. So the other way is a ACCORD study which they did cardiovascular mortality. In that they found out that strict control of HbA1c also helps. But that is slightly life-threatening because cardiovascular mortality is slightly higher if you do intensive control. So here they found that fenofibrate does help, but it only cases with mild NPDR. And if you have no NPDR or no DME, then it's not beneficial for DME either. Only in mild NPDR you can reduce the progression. So in moderate to severe NPDR, we still don't have anything except control the major risk factors, which has been told to us as anemia, lipids, renal disease, etc. But there are certain periods which you must look for, follow up for pregnancy, puberty, and after cataract surgery. Now, NPDR with DME is what Sir talked about. Ranibizumab is now the first-line therapy for central involving diabetes mellitus. But it has also been approved, and FDA has also approved it for non-center involving. Only thing is, most of us are not giving it for non-center involving yet. The reason is you have to give it monthly treatment. So sometime it is combined ranibizumab and laser treatment which helps. So focal laser photocoagulation has been told to reduce moderate visual loss. Moderate vision loss is 20/70 to 20/160. This has already been told to us by ETDRS. So what is moderate NPDR with DME? You are seeing the moderate disease and you are seeing central involved maculopathy. They found that there was a 2-step improvement in patients who were getting diabetic retinopathy and the quality of life improved. It also improved the probability of a new proliferative event is less when you give injections of monthly dosage. And that was studied by Protocol W, where they decided to look for aflibercept in PDR. And they found that there was an less incidence of DME and less need for vitrectomy. So the disease rapidly involutes with the anti-VEGF, but the compliance is very difficult. So basic thing is identify the STDR and refer for surgery before severe visual loss occurs. You don't refer after visual loss occurs. And remember that younger patients with PDR are at a higher risk of visual loss. So take-home messages, give recommended ophthalmic care, which should reduce the prevalence by 52% of blindness. And direct cost of the care is lesser than the loss of productivity and cost of disability facilities. Thank you.
Thank you, Madam, for that wonderful talk. Next, I invite Dr. Rekha for her talk on lasers in diabetic retinopathy. Is it losing importance?
So good afternoon, everybody. First of all, I would like to thank Sudha Madam and Papa Madam for giving this wonderful opportunity. So coming to the topic, is laser losing its importance? So studies have shown that in PDR, both anti-VEGF and PRP treatment has got similar results regarding the visual acuity and control of neovascularization, but anti-VEGF has got its own advantages. So first of all, coming to the basics of laser, you all know the mechanism of action of PRP. There is destruction of the photoreceptors in RP, which is the most metabolically active cells, which decreases the oxygen demand, thereby decreasing VEGF, and also it decreases the vascular permeability. Regarding focal laser, it touches on the leaking microaneurysms, which will help in resorption of fluid, and it improves the oxygenation and thereby decreasing macular edema. So there is a general trend that PRP means just a few laser shots around the arcade. So we'll see what is the most appropriate technique. First of all, the settings of PRP. The spot size, it is, you can remember by the 200, 200, 200 rule. That is spot size at 200 microns, duration 200 milliseconds, power can be kept at 200, spacing 1 burn width apart, and the total number of burns can be 1500 to 2000 in 2 settings. In focal laser, the spot size and duration is lesser than PRP. Now coming to the extent of laser, how anteriorly laser shots can be given up to the equator. Equator can be identified by the ample of the vortex veins. And the posterior extent, superior and inferior quadrants should be given just outside the arcade. Nasally should be given up to 1 to 2 disc diameters away from the disc, and temporally 2 to 3 disc diameters away from the fovea. But certain areas should be avoided. That is 3 and 9 o'clock position should be avoided as there is a long ciliary nerves, then ample of the vortex veins, over major retinal vessels, and also directly over the pre-retinal hemorrhage and chorioretinal scar. Now coming to the complications of laser, the most important complications according to the patient will be night vision difficulty, defective color vision and field restriction. Also other complications are aggravation of macular edema, appearance of choroidal neovascularization, subretinal fibrosis and secondary angle closure glaucoma. Now, to tackle all these, we have the newer laser techniques, that is multi-spot laser. We have the Pascal laser, where the laser shots are given in a preset pattern. Up to 64 spots can be given at a time. So it will reduce the exposure time. Then we have the sub-threshold micropulse laser, where laser is divided into short repetitive pulsar. We have an on time and an off time. So this off time is helping for heat dissipation, and it decreases the collateral damage. Now, next is a targeted retinal photocoagulation. Here, the peripheral, non-perfusion and ischemic areas are identified using an ultra-wide angle FFA, and these areas are targeted for laser. So we can have fewer laser points. It will minimize the complications of laser. Now, next question is, which is preferred, laser or anti-VEGF? So we will see some clinical scenarios. This is a patient with center involving macular edema. Here, there are many studies to support that anti-VEGF is the treatment of choice, and also it has an advantage that it will promote the regression of diabetic retinopathy also. Next is a non-center involving macular edema. Here, focal laser is a good choice, and it is usually preferred for extrafoveal succinate maculopathy, and also in conditions where anti-VEGF is contraindicated. Now, next is PDR. Here, anti-VEGF and PRP has got similar results regarding the anatomical outcome, control of neovascularization, and also visual acuity outcome. But anti-VEGF has the advantage that it has a better visual field. The diabetic macular edema and vitreous hemorrhage incidence is lesser, and also there is a less progression of PDR. Now, next important factor in our setup will be the patient compliance. Anti-VEGF treatment requires more intensive treatment plans. The patient compliance is a very important factor. So you should talk to the patient regarding the available transportation to the clinic, the family support, and the work-related issues. And also multiple injections has got the risk of endophthalmitis, and it is not preferred for patients with multiple comorbidities. So if patient compliance is a problem, then PRP is preferred. Next important factor is the cost factor. You know, the average number of injections. We usually advise monthly injections for 6 months, and after 6 months, again reassessment is done regarding the control of neovascularization. If it is not controlled, again monthly injections for 6 months is advised. So we can imagine the financial burden the patient has to take. So if cost factor is a problem, again, PRP is a preferred mode. So personalization of the treatment plan is a key factor. We can combine laser PRP and anti-VEGF, but it requires more studies. Thank you.
Thank you, Rekha. Next, I invite Dr. Geeta for her talk on steroids in diabetic retinopathy.
Good afternoon. Let's see what is the role of steroids in diabetic macular edema. We all know what is the pathophysiology of diabetes. Hyperglycemia causing breakdown of blood-retinal barrier with releasing VEGF and inflammatory mediators, ultimately leading to development of macular edema. So if you are injecting anti-VEGF, we are dealing with the vasogenic arm. So what about the inflammatory arm? Here comes the role of steroids. In diabetic macular edema, there is upregulation of various interleukins and adhesion molecule, and moreover, there is altered expression of aquaporins in Muller cell, causing redirection of fluid within the retina, causing more and more retinal edema. So what is the role of steroids? Steroids have special role in long-standing edema. Why? Because in chronic edema, the VEGF level will come to a normal level or sometimes even low, along with high levels of inflammatory markers. So that is why some of the recalcitrant macular edema cases are showing better response to steroids than anti-VEGF. So steroids are not only anti-inflammatory agents. By downregulating the this expression of VEGF agents, they are also anti-angiogenic. Steroids are always second-line agents after anti-VEGF, but these are some of the specific indications in which you can have a trial of steroids. Among these, most important ones are persistent diabetic macular edema, patient with multiple comorbidities, and pseudophakic eyes. So what is persistent diabetic macular edema? According to the DRCR, NET and VISTA-VIVID studies, it is failure to achieve a central foveal thickness of less than 250 microns or at least 10% reduction for a period of 6 months, even after injecting 4 monthly injections of anti-VEGF over a period of 6 months. So in this persistent diabetic macular edema, steroid has better role than anti-VEGF. So there are certain biomarkers which will tell you which all subset of patients will respond better to steroids than anti-VEGF. These are presence of baseline subretinal fluid, severe extensive submacular exudation, and hyperreflective foci. We all know what are the contraindications and documented side effects of steroids. So what are the different options? Among these, topical and anterior subtenon, they won't reach sufficient concentration in posterior segment, so they are not at all used for treatment of diabetic macular edema. So the different options are posterior subtenon, intravitreal injections, implants, or suprachoroidal injection. Posterior subtenon, in the earlier studies, have shown better result with subtenon. The advantage is it is less invasive with lesser side effects compared to intravitreal route. But protocol E study of DRCR net have not shown any promising result with posterior subtenon. So nowadays we prefer intravitreal route compared to posterior subtenon. We can inject triamcinolone in a dose of 2 mg or 4 mg, but the problem is it is an off-label drug and the FDA is not approved yet for treatment of diabetic macular edema. So why we are giving DME? That is because of the result from protocol I trial of DRCR net, in which they have shown IVTA plus laser has efficacy almost similar to ranibizumab plus laser in pseudophakic patients. So, but the problem with posterior subtenon and intravitreal is it is shorter lasting, so we have to inject repeatedly after every 3 to 4 months. So if we inject some slow release implants in a lesser dose, it will be more beneficial to patients. So that has led to the development of steroid implants. These are preferred mainly in patients who are difficult to follow up or victimized patients or macula showing extensive exudation. Among these, most important one is biodegradable implant, that is KSOS is the commonly available drug in a dose of 700 microns. And it is the one approved for use in diabetic macular edema by FDA with a duration up to 6 months. Fluocinolone implant is a non-biodegradable device. The advantage is it will last up to 3 years. As the duration increases, definitely the complication will also be more. So it is less use, and options are Iluvien, and Rectisert is mainly used for posterior uveitis. It is not approved for diabetic macular edema. And suprachoroidal injection is the newer promising route in which there is direct targeted therapy to the retina and choroid with a better safety profile. We have to use special microneedle, and so many studies are going on the suprachoroidal injection. So this is nutshell about the different options among steroid. Now we can come to different case scenario. In our medical college setup, there is no provision for anti-VEGF, so we are injecting intravitreal or subtenon steroid in selective cases. So in first case, patient presented with very dense cataract. He had multiple comorbidities like stroke and CAD. And this is the fundus picture, and this is the baseline OCT picture. So the anti-VEGF was contraindicated. We have given IVTA along with cataract surgery, and this is the picture at 1 month, and this is the OCT picture at 3 months. The vision was improved to 6/9. The other eye also, patient underwent the same procedure, and he got 6/9 vision. In the second case, the patient was diabetic, and you can see it is a very dense brown cataract in a poorly dilating pupil. The surgery was done with pupil dilating devices, and postoperatively patient developed pseudophakic macular edema. And with IVTA, this is the 6-fix picture with 6/12 vision. In third case, the patient presented with lens-induced glaucoma. There was soldo dialysis, so we could implant only the iris glow IOL. So we have given the patient developed postoperatively pseudophakic macular edema. We have given the posterior subtenon. The vision was surprisingly improved to 6/6. And this is the last case. You can see it's a central involving macular edema in a very dense cataract. The fundus, the view was very hazy. We could take only a line scan. And we have given subtenon, posterior subtenon along with cataract surgery. And the vision was improved to 6.6 at 3 months. So if we carefully, even though it is a second line agent, if we carefully select some of the patients or some of the cases, steroid could do some additional benefits in diabetic macular edema. Thank you. Thank you, madam, for this opportunity.
That was a good talk on steroids use in certain, especially during cataract surgery or after cataract surgery. But when we do a treatment, we should also know when to stop medical treatment. That is the most important. Can't keep on injecting in a patient who will not gain vision. So that is our next topic by somebody who is, of course, going to be our next president, Dr. Thomas Cherian from Angamali. So when to refer.
Thank you, Papa and Sudha, for this invite. Diabetic retinopathy is a disease which is primarily treated by the medical retina specialist and followed up maybe by the comprehensive ophthalmologist. But there's a certain point beyond which a medical treatment does not work, or beyond which keeping on with medical treatment might not be in the good interests of the patient. So that is when you have to refer this patient for a vitreoretinal surgery. The commonest indication for a vitreoretinal surgery in diabetic retinopathy is a vitreous hemorrhage. Not all vitreous hemorrhages need to be referred immediately, but a persistent or a recurrent vitreous hemorrhage needs an early referral. And also you have to look at whether the eye has been lasered previously or is it an unlasered retina. If it is a lasered retina, you can probably wait for a few weeks before you refer, because these vitreous hemorrhages could get absorbed over a course of time. But an unlasered retina, unless you refer it promptly and initiate a surgical treatment, the disease process underlying the hemorrhage could progress and end up in a more serious condition where even your surgical treatment might not yield good results. So an unlasered retina with a vitreous hemorrhage has to be referred as early as possible, while a lasered retina could be probably kept under observation, and if it persists, can be referred. One-eyed patients need a prompt referral. Bilateral cases end up in blindness, so needs a prompt referral. If there's an anterior segment neovascularization in the patient, that means this is not going to clear up easily with your conservative management, so it needs a referral and an initiation of surgical treatment. It's a non-clearing dense vitreous hemorrhage. And this is an eye where it is an unlasered retina. There is a hemorrhage. There are some sclerosed vessels around which needs an early referral. This is one case where I would probably look at the visual acuity. It's better to refer and leave that decision to the vitreoretinal surgeon, but before you intervene, I would probably look at the visual acuity and also keep a very close watch on the progression of the disease before I go in, because the macula is mostly normal and it might stay like this for some time and the hemorrhage could clear up or could worsen, either way. What is the role of anti-VEGF in proliferative diabetic retinopathy and vitreous hemorrhage? We go by the DRCR net, the protocol AB, where you have the aflibercept versus vitrectomy. In a vitrectomized eye, the anti-VEGF might clear faster. So if you plan to inject anti-VEGF later on, then probably withhold the vitrectomy for some time and see for the progression. Your anti-VEGF might work, but if it doesn't, go for a vitrectomy. If there is significant neovascularization, there is no point in waiting, because the risk of fibrosis and a tractional retinal detachment are much more. So an eye with a significant neovascularization needs a vitrectomy. Stable extrafoveal tractional detachments, you can probably observe no need to go in at the earliest. Look for progression, document the progression, and if there is progression, refer for a VR surgery. A combined tractional and rheumatogenic detachment most of the time needs a VR surgery, so refer early. And have a case like this. I would withhold surgery in this patient. If this patient has some 618 or 624 vision, I might still withhold surgery because that is the best possible vision you can probably have even after surgery. So this doesn't need an intervention. Of course, if the medical retina specialist who is practicing feels that it needs a referral, please go ahead and refer. Otherwise, this can probably be observed. Preretinal hemorrhage at the macula needs a referral because these preretinal hemorrhages at the macula, that is different from the Valsalva retinopathy. A Valsalva retinopathy, you can probably do a laser and get rid of that. But a preretinal hemorrhage at the macula in a proliferative diabetic retinopathy, you have a tough preretinal membrane which doesn't give way, so that needs an early intervention. And left untreated, left with conservative management, this can go for a scarring later on and the final outcome might not be very good. An epiretinal membrane at the macula without macular edema with significant visual loss. Without macular edema, your anti-VEGF or steroid is not going to work, so the epiretinal membrane has to come out, needs an early referral. An ERM with the DME, you can probably go for an anti-VEGF or a steroid first, look for the toning down of the macular edema, see if there is a visual improvement to your expectation. If so, leave it. Not just leave it, keep under observation, and if not, plan for a referral. If you have a vitreomacular traction with significant or progressive visual loss, it needs a referral. The vitreomacular traction has to be relieved for the vision to be restored. So this are some preretinal hemorrhages which we come across in our practice. The one on the left side, that is a large preretinal hemorrhage, obviously sparing the fovea, but this vision, the patient might have something like a 6/9 or 6/12 vision, but you have a significant vitreous hemorrhage if you see that inferiorly. So this needs a referral and early intervention. And the one on the right side, it's a well-lasered retina. There's a good panretinal photocoagulation done, but that preretinal hemorrhage is obscuring the macula. So this eye might have only something like a 6/60, and if you operate, he is going to get a 6/6 or 6/9 vision. This needs an early referral and an early intervention. This is another tricky situation where you might land up. This has a lot of neovascularization and fibrosis. It's a thick fibrous membrane covering the entire posterior pole. This patient I kept on observing because I was a bit scared that it might burn my fingers. The patient had 1/60 vision. The other eye had 6/6. So I kept pushing it off until the patient pushed me into surgery, and the patient landed up with a good visual outcome. The membrane came off as a sheet and the patient's vision improved to 6/36. In proliferative diabetic retinopathy, severe progressive PDR despite maximum laser, if the disease is progressing, if the neovascularization is progressing, you need an early intervention. And in a PDR, before taking up for a vitreoretinal surgery, either do a maximum PRP, whatever is possible, or inject, or both before you take up, because these florid PDRs are going to bleed, and they bleed badly when you take up for surgery. This is another case where we have a reasonably good laser with hemorrhage obscuring the posterior pole. This needs an early referral and early intervention. Over the past 4 decades, until the recent advent of anti-VEGF therapy, the mainstay of PDR was thermal laser to regress neovascularization, and treatment indications are still largely based on findings from the DRS. Photocoagulation reduces the risk of severe vision loss of 50% or more compared with untreated control eyes for 5 years of follow-up. If PRP has been performed previously, earlier intervention is usually recommended. PRP has not been performed previously, and the threshold for a VR referral should be low. Patients with a good PRP done earlier with vitreous hemorrhage may be observed before sending for a surgical intervention. When you are holding back your patient with a vitreous hemorrhage without a surgical intervention, you have to have a serial ultrasound to look for development of traction or a detachment. Have an ultrasound and look for the posterior pole. And patients with bilateral severe vitreous hemorrhage, you can't wait. Obviously, you have to operate at least one eye to restore the vision and make the patient ambulant. DME secondary to ERM and taut posterior hyaloid, unresponsive to intravitreal injections, needs surgery. And this is a PDR with preretinal hemorrhage. Aggressive neovascularization of the disc needs an early clearance and photocoagulation with oil. TRD sparing the fovea. This is one case where I might not go in. Keep observing. This might stay on for years together like this. So you need a referral, but leave that decision to the VR surgeon. TRD involving the macula needs a referral. No other way this is going to improve. And the rate of progression of extramacular TRD to involve the macula ranges from 14 to 15% at 1 year and 21 to 23% at the end of 2 years. So role of PRP and vitrectomy, preoperative PRP may be considered with TRD if the eye has not received any lasers earlier. Though it helps stabilize the PDR, it has a risk of developing a retinal break and tractional detachment. So when you are lasering an eye with TRD, always stay away from the base of the TRD. However, keep a safe distance so that it's safe. It may also reduce the time needed to complete endolaser photocoagulation during your surgery. Thank you very much.
Thank you for that. And Dr. Thomas Cherian is going to leave any questions you want to ask. I just have one question for both of you, sir. You decided on surgery. What is the real life scenario? Do you really get vision, better vision in how many percentage of cases?
It's not. The truth is that in the recent years, the outcome of surgery with the MIVS has vastly improved. The reason for this advancements in mainly advancements in viewing systems, so we can see much better than the older. We had a very narrow field, the contact lenses. Then the surgical instrumentation has improved, and then finally the techniques have evolved a lot during this few years. If you look at the DRVS trial, they said that do not operate patients with below 6 months of when the vitreous hemorrhage is only less than 6 months. If you look at the study results, this recommendation was based on not positive outcome but negative outcome. During the DRVS trial, it was conducted in 1970s. If you operate 3 people, 1 person will go for no peer because there was no endolaser at that time. The viewing systems were not good. The surgical instrumentation was very bad. Techniques had not evolved. So out of every 3 people who operate, 1 person went for no peer. That's why they told do not rush to do surgery, wait and see, because it was not based on negative outcomes, not positive outcomes. But that has totally changed down the years. The threshold for advising surgery has become very, very low. We are happy to operate even in 6 parts vision. Unlike olden days, we used to wait for the vision to come down to close to PL or 160/260, then operate. But right now, all these advancements have helped us to operate on eyes with very good vision. And also the prognosis has been very, very different compared to the DRVS study results. So we are now happy to operate. We are more confident in giving better outcomes. That's why what we already showed. No, if you ask him if we operated 20 years back, he would say no. That's what I'm trying to put.
Yeah, and there are situations where you operate because you expect a good visual outcome, and there are situations you operate because you are no other way. The first group of patients, you go in early and operate. The one group of cases where you shouldn't really operate is those who are maintaining a vision for quite some time without any real progression, but they have a TRD, they are maintaining vision, especially those one-eyed patients. I would prefer not to operate.
Okay, so that's a very valuable lesson that we do go into early surgery now, but you should know when to refer for these cases. Now, the last talk of the day is role of anti-VEGF in diabetic retinopathy by Dr. Papa, Associate
thank you.
Professor, RIO Trivandrum.
Okay. Thank you, KSOS, for giving us this platform. So mine will be a very basic presentation of anti-VEGF in diabetic retinopathy. So when will you inject? Again, the common indication is central involving macular edema, and the CSFT is more than 315 microns in males and 305 in females. That is the Heidelberg measurement. And how you are injecting, what is the frequency of injection? You can follow either two regimes, the PRN regime and the treat and extend regime. In PRN regime, actually we are giving monthly injection till the visual acuity and the OCT stabilizes. Then you follow up the patient monthly, and if you are seeing any signs of activity in OCT or the vision deteriorates, you can inject. But in treat and extend, what you do is after the 3 loading doses, you can extend the interval of injections by 2 to 4 weeks. If the visual acuity is stable and the OCT is also stable, then the injection intervals you can extend up to 3 months. And in between, if you are seeing any signs of worsening, you can decrease the intervals by 2 to 4 weeks and give monthly injections. Now, previously we used to do the grid laser. Now we have changed to the anti-VEGF. So why not laser? These are the different studies which shows that the long-standing visual outcome and also the macular edema, the better results are with the anti-VEGFs. Lasers, of course, you can give in pregnancy and in non-central involving macular edema if the visual acuity is less than 6/9, and you can actually combine anti-VEGFs with laser. Now, this one patient with 4 injections in 6 months, you can see the response. The cystone macular edema has come down. And this patient with 3 injections of biosimilars, vision improved from 636 to 69. This is the patient with 2 injections, 6/60 to 612. So it is not indicated in certain situations like ischemic macula. And as Thomas was telling, taut hyaloid, ERMs, and there is vitreomacular tractions. And in some systemic conditions like diabetic nephropathy, even if you inject with SRF and cystoedema, the patient may not respond. So you have to control the systemic factors, then only inject. And if the patient has a recent MA or stroke that is within 2 months, it is better to withhold the anti-VEGF injections. Now, certain biomarkers in OCT, they shows poor response to anti-VEGF, like the drill or the ellipsoid zone or external empty membrane disruptions. Steroids, you can give if they, as Geeta was telling, failed anti-VEGF trials, you can wait for 6 months not responding, you can give steroids. Usually long-term steroids like DEXA implants are preferred. And in conditions like if anti-VEGF is contraindicated, but the chance of cataract and glaucoma should be explained. Then the choice of anti-VEGF. So as Sir was telling, if the patient has a mild visual impairment, all the 3 works, that is aflibercept, ranibizumab and bevacizumab gives good results, the same results, but the vision is moderate to severe, the aflibercept is superior to the other 2. So when will you change an anti-VEGF? If you are seeing less than 20% reduction in central retinal thickness, even after 3 to 6 injections, or less than 5 letters improvement, you can change the anti-VEGF. If you are using bevacizumab, you can change to ranibizumab and then to aflibercept. Now, what is the role in NPDR? So the different studies where anti-VEGF is given for central involving macular edema, it shows that it actually arrests the progression to PDR also. And there is a decrease in the diabetic retinopathy severity scale also. And this action is better in severe NPDR compared to mild NPDR. Now the PDR. So what is the role in PDR? So these are the different studies which shows that at 2 years follow-up, the visual acuity is better in injection patients, visual field is better, and the need of vitrectomy is also less. But at 5 years, the results are comparable except for the visual acuity part, which is better in the injection group. So all depends on, in a country like India, again the cost factor, patient complaints, and the associated risk of intravitreal injections like endophthalmitis should be explained. So in a case like this where you are seeing a high risk PDR without macular edema, Again, laser, PRP is the gold standard, and you can give anti-VEGF if there is macular edema development, and there is a hybrid approach you can choose. If it is a high-risk PDR with macular edema, anti-VEGF is the first line of treatment. And patients like this post-PRP with rebleed, you can do add lasers, but injection also works in these patients. In case of advanced diabetic eye disease, prior to vitrectomy, 1 week prior to vitrectomy, we can inject so that it reduces the intraoperative bleeding during vitrectomy. And a pre-retinal hemorrhage, so was showing. The treatment of choice is vitrectomy, but you can try one injection of anti-VEGF. In bilateral fresh VH, if there is no retinal detachment, again you can try one injection of anti-VEGF. Now the newer anti-VEGFs, the most commonly used ones are the brolucimab and the faricimab. Advantages are less number of injection, more disease control. Now biosimilars, what are they? They are comparable in quality with the original molecule. They are similar in pharmacokinetics, pharmacodynamics and efficacy. Advantages are very cheap and less time for production. And the complications are again the reactions because of the immunogenicity. These are some of the biosimilars for ranibizumab. Now, biobetters, what are they? They are actually better than the original molecule, but it's an investigational new drug, and the cost is also very high. So that's all. Thank you for the patient hearing.
So thank you. With that, we come to the end of this session. Any questions? We can just take one question if any need. Okay.